My disclaimer is that anything I say does not represent necessarily the views of Sydney North Health Network, MHPN, or CCMB. So I'd like to start by acknowledging and respecting all ancestral lands of Australia's First Peoples, and acknowledge that we meet today on Aboriginal land, always was and always will be. I'd also like to acknowledge the elders of all the communities in our area. First Nations cultures have survived on this continent for over 80,000 years, and had and have no need for royal commissions to direct them in compassionate and respectful care of their elders. We now have an opportunity to learn from them and co-create a nation that is proud of and embraces the history, culture, and rights of First Peoples, their elders, and other cultures for present and future generations.
I'm in Gadigal land here in Marrickville, and I too pay my respects to elders past, present, and emerging. And, you know, certainly echo Stephen's acknowledgement of country, where he said we have a lot to learn from First Australians, particularly when it comes to caring for and including older people. Just at the beginning of the session, and I'm sure at the end of the session, many thanks to Michelle Ferris, my colleague at CCNB. And for those of you that don't know, Michelle has been at CNB as our dementia consultant advisor, and it is with regret that we see her leave CCNB this Friday, but hopefully we will still have a strong connection with Michelle as she moves on to her new role. So Michelle, thanks for certainly adding value to this network, and I'm sure Stephen will have some words to say about that at the end of this session. I want to start off by also saying I'm not an expert in everything bureaucracy, but it's fair to say I like to be a bit of a commentator. And so my views tonight are my views. They are not CCNB's views. And I will be honest about what I think, and also hopefully encourage you to also maybe critique the recommendations, delve into your own practice and your experience, and try and make sense about what the impact may or may not be about what is yet another Royal Commission. So the first question, and I want you to use the chat if you can, is just tell me how long you've been in this sector, in the business of supporting older people with or without mental health problems in a changing sector. More than 5 years, more than 10, more than 20, or if you're like me, more than 25 years in the sector. So just maybe pop that in the chat room. How long have you been in this business? Are we chatting? Are we popping it in the chat room or in the Q&A? No, there you go. It's in the Q&A.
Chat.
Chat, okay. I've got Dane that says less than 5 years. Thank you, Dane. You're a newbie. 2 years, 6 years, since 2015 from Reem, 2 years from Lillian. Who's been around for more than 20 years? 10 years plus. Thanks, Jane. Stephen, more than for rubbish. Were you doing in utero?
First thing I did in medical school. Oh. First person I saw was an older person.
10 years, says Ruby, but it's only a very small area of my practice. 12 and 10 years. Doing my PhD on dementia. Excellent, Joanna. Smart move. Be interested to hear about your PhD if time permits. That would be great. Okay, so we have a mix of experience in the Zoom which is terrific. Thank you for answering that. I've been around for 25 years at least. I also begin by saying I'm cared for my grandmother a long time ago, and as it happens, I'm also caring for my mother who has dementia. In fact, just before this session, I had to chuff over to her house. She lives 7 kilometres away to supervise her shower this afternoon because things are getting tougher for her to do. And, you know, there's an issue of safety. And that's a great segue to talk about this Royal Commission. I don't know if you know, and I don't know if you care, but let's talk a little bit about what's a Royal Commission anyway. And it's basically an investigation independent of government into a matter of great importance. And of course, aged care has been a matter of great importance for successive governments over certainly the last 60 years or so. These Royal Commissions have these broad powers, and it's usually the government, well, it's only the government, federal government of the day that can call for a Royal Commission and get the tick from the Governor-General. And they get broad powers to hold public hearings, call witnesses under oath, and compel evidence. Their role is to hear that evidence and to make recommendations. But I also think a Royal Commission is about stalling action to enable governments to build a stronger election platform. Call me cynical, but I told you I was going to be a little bit honest about what I think. Doesn't mean I'm right. It's also a great opportunity to blame others. It can, and it does, reshape public policy conversations that ultimately can reshape public policy. It does expose faults and problems and mistakes and corruption and abuse. And they have to kind of, all these Royal Commissions, they cost a lot of money, take a lot of time, put forward recommendations to fix the problems identified. So it's no good just to say, oh yeah, shit, we're in trouble. But they actually have to make strong suggestions, strong recommendations about what we should do to fix the problems that have been identified. I don't know if you know, but since 1902, first federal government, we have had 134 Royal Commissions, and I had an absolute ball going through the history. I did have a couple of glasses of wine when I did go through that history, but just the breadth of issues, public policy issues that was subject to a Royal Commission, and just the politics of the time were awesome, because there was no Royal Commission unless there were politics at the time. So, you know, the first one was a Royal Commission appointed to inquire about the arrangements made for the transport of troops returning from service in South Africa. So that was an interesting time, because there was obviously argy-bargy around who was going to pay for these troops, how we were going to get them back, what the risks were, etc. So Royal Commission had to have. Then in 1904, there was a Royal Commission into the butter industry, because no doubt there were significant problems about how we were producing butter, how much we were taxing butter, who had the ownership of the butter. Was it the farmers that provided the milk? Was it the farmers that actually owned the land that had the cows that provided the milk? Was it the actual butter churners? So why not? Let's have a Royal Commission into that, because it was big business and big industry at that time. 1905, we had the first Royal Commission on an old age pension. Royal Commissions into the tobacco monopolies, food supplies and trade. You can see it. Royal Commission into the basic wage. 1925, we had a Royal Commission on health. And a lot of these Royal Commissions were the impetus of some social policy reform, but they were certainly the platform for politicking and positioning political agendas. Just for further interest, please keep asking questions and making comments. Of course, 1929, Royal Commission into the coal industry. 1978, Royal Commission on Human Relationships. Does anyone know what that would be about? Yeah. It was basically the first time we started really talking about sexuality and relationship and what was accepted and what wasn't accepted. So that, we had to have a Royal Commission because the politics were getting tough. It was around the time of the women's movement that was gaining momentum. So government was feeling the heat, so they had a Royal Commission. 87, some of us will remember the Royal Commission of Inquiry into the Chamberlain convictions. That was really driven by the problems that whole case and the conviction of Lindy Chamberlain in the end, and the role media played. That Royal Commission went through, made a range of recommendations, but one of them was how the media reports on stuff. And it obviously had a nation divided, and the government of that time needed to provide a position. So a Royal Commission was the way to go. Aboriginal deaths in custody, institutional responses to sexual abuse, Royal Commission into aged care, quality and safety, which is what is bringing us together tonight. And as we speak, there is a Royal Commission into violence, abuse, neglect and exploitation of people with disability. And I'm not sure when those findings are going to come down. I don't think I'll be able to read them till I've fully recovered from reading the Aged Care, Quality and Safety Royal Commission. Any comments about a Royal Commission and the history of Royal Commissions? Or can anyone remember the findings of, I certainly remember the findings of the Aboriginal deaths in custody. I remember marching, remember going to, as a young uni student to Redfern. It was a really, really tough time, but it was also a really important time for First Australians. Anybody else remember? Stephen, don't tell me you remember the coal industry Royal Commission.
It's the latter one I remember best. The Aboriginal deaths in custody, I mean, let's not go into the past. There were 2 in the last couple of weeks.
Yeah.
There are 3 new messages, so that'll be. Anyone else?
No? Okay. Is there any comments? I can only see the Q&A. Is that what you're looking at?
Child sexual abuse. In the chat room, Jessica's telling us, fascinating, I was a child protection caseworker when the Child Sexual Abuse Royal Commission was happening.
Yeah. And Jessica, can I ask you, what do you think changed? What was one of the things that has changed as a result of that Royal Commission into institutional responses?
Can you unmute yourself, Jessica?
Sure. Something is happening to my tap in my kitchen, so I apologise for the noise in the background.
We'd like water.
Yeah. It was so long ago. I was this baby graduate, social work graduate, and I remember that there was huge reform, and it was just the whole of fax was a bit of a mess, to be honest. But there was a lot of talk of babies in suitcases and a lot of child deaths in custody, and a lot of case studies that we had to read in preparation for being a caseworker. There's a lot of emphasis on training at the time as a result of the 2013 Royal Commission. Yeah.
And I think one of the significant outcomes of that too, because it was around sort of institutional responses, was better collaboration between how health and, sort of that whole of government approach was introduced, where health and justice and education were to work more closely and share information with the police around young people at risk. That sort of probably had the most significant practice impact, because prior to that, government departments never spoke to each other. So
I remember now. Yeah. I can't remember the act's name, but there was an act name that we would quote every time we would call the police to ask for information. And every time we'd quote it, then they just hand over everything. Yeah.
Yeah, indeed. Okay, so that's about Royal Commissions. That's setting the scene, letting you know that this aged care Royal Commission on Quality and Safety is not the first time. There's been Royal Commissions where recommendations have been ignored. There's been Royal Commissions where recommendations have really driven reform. So are Royal Commissions good? Yes, they are, my view. Yes, they are. Not because they find facts that we didn't know. I think a lot of us who've worked in this sector for a long time know and understand the deep systemic problems that the sector has. But what it does, it gives us, just like it gives the government of the day, a political platform to affect some change. So Royal Commissions are absolutely political, absolutely political. Just to remind us all, this Royal Commission had a specific job, and initially they talked about it being quite broad, and then the government sort of pulled it in and said, whoa, let's just be really clear. What we want to find out is about the quality of aged care services in Australia. We want to try and understand how we can best deliver services to people with disabilities in aged care facilities, including Australians living with dementia. The Royal Commission needed to go out on a fact-finding mission. They also needed to try and, bring in all the acumen, the knowledge of people with lived experience, older people, their families, service providers, to better understand the future challenges and the opportunities. Nothing wrong with that. The government also wanted this Royal Commission to give some ideas and recommendations about how we can all strengthen this system and how we can all make sure this aged care system is high quality and safe. Just remember that term, high quality and safe. How to ensure that, services are person-centred, and basically how to deliver services in a sustainable way and innovative models of care, and anything else the commissioners thought was important. So basically, when I first read the scope of the commission, I thought, all right, when they talk sustainability, they're really talking about who's going to pay. Because whenever we talk sustainability, it really is about who pays. When they talk innovation, they're really going to talk about doing things differently so it costs government less. I'm just deciphering, I'm translating for you. I might not be interpreting right, but that's my translation. Person-centred, well, they've got to stick that in because that's been sort of the tenet of care probably since the early 90s. What does that even mean? But let's not argue about that yet. What can we all do to strengthen the system? That's government saying, hey, look, we don't want to carry all the risk. This is, you know, it takes a village to raise an older person or care for an older person, which is absolutely true. But that is absolutely about shifting responsibility. High quality and safe, that's about risk, and government saying we want to cover our butts and we want to make sure things are high quality and risk-free. So we're going to make people and providers jump through a whole lot of hoops. And if they can't, we're going to push that risk back down to the older person and the daughter that goes and supervises mum's shower at 5 o'clock. The future challenges and opportunities for delivering accessible care and affordable high care. They're basically saying, yeah, we actually don't know because we're government. Can we get some ideas from people? And the disability issue around younger people with disabilities in aged care is, how is our aged care system going to fit in with the NDIS? Where's the overlap? And quality is, let's have a bit of open disclosure here. Whilst there's some great services, fantastic services, residential and home care, it's inconsistent and not all services are great. That is my interpretation of the scope of the Royal Commission. I'm not saying I'm right, but I definitely saw the process through that lens. So keep asking questions, everyone, through the thing. I'd really appreciate that. So they, you know, had 28 months of work. They had 23 public hearings. They had 641 witnesses, over 10.5 public submissions. What do you think they found out? What do you think the evidence was? Anyone want to put their hand up? Stephen or Michelle, can you see anyone putting their hand up?
No, but if anyone puts their hand up, the first one to put their hand up can unmute themselves. How about that?
Okay, sounds good. Does anyone have any idea what they would have found after 28 months of work, 23 public hearings, 641 witnesses, 10,500 written submissions?
Marika, the answers are coming through. Aged care system not working, neglect and abuse, gross evidence of systemic abuse and neglect.
Thanks, Michelle. Thank you, everyone who's put that.
And yeah. Ruby Joe earlier mentioned it's always difficult to accept how few recommendations are actually implemented.
Yeah, yeah. So what they did, which is unprecedented, they provide an interim report in October 2019, whilst the Royal Commission was happening. So government said, shit, there's a lot of bad stuff. We're going to have to do this. Let's take the sting out of the final report. Again, remember, my views, not CCMB's, my analysis, no one else's. Let's just get this, this out of the way. Let's have open disclosure. It's a shocking tale of neglect. That's a fantastic interim report. But I have to say, I read it back in October or December in 2019, and I cried because the stories were so moving. I mean, the evidence that was provided, you know, I not only I cried because of that, but I also felt so incredibly guilty as someone that's been in this sector for a really long time, that knew stuff like that happens, absolutely knew stuff like that happens, but haven't been able to actually change it. And I'm not saying I'm responsible for changing it, but I did. I felt bad as someone that works and loves this sector to hear these shocking tales of neglect. Very smart move by the government and the commissioners, who are independent, to release this interim report. Very politically smart, because it basically shifted those tales of neglect out of the recommendations that they want to focus on now. But everyone who's just shared online what they found out, you're right. Basically, the system wasn't working for people. It is true that the focus was very much on residential aged care. And, you know, as if it wasn't scary enough for an older person to even think about resi care, what this interim report did was, you know, people would, people in their families would avoid it at all costs, which is a little bit unfair on some great residential aged care providers. And it's also unfair on older people and their families where residential care is the only option, or the best option for them. But there was inconsistencies, there was poor care, there was unkind care, there was abuse, there was neglect. It was stuff that we kind of knew, and stuff that some of us and many of us had been working on to change, but it was right there, black and white. We've got problems in our system.
I think that word unkind jumps out at me, because it can reflect quite a major part of our culture as it's evolved into a materialistic culture. And I've just been looking at Hugh Mackay's book, it just came out, called The Kindness Revolution. If anyone hasn't had a look at that, I think kindness, it's an important aspect of care at any age.
Indeed. And I think we'll find that one of the recommendations and the word certainly that the Prime Minister has been using has been kind and kindness. And interestingly, the providers who were most, the stories about providers who were most unkind and uncaring were interestingly government providers of care, predominantly residential care, which I think is something also about, the issues of bureaucracy and bureaucratising care. And kindness. I'm not sure we can create bureaucracies around kindness. I'm not sure I want that to happen either. So values-driven services are really important, and having people who come into this sector. I know that we have students who come into CCMB, and I've supervised students in my years as a social worker, and I often say to them, if you don't have a fire burning in your belly about things being unfair, and if you don't genuinely care about the people you serve, don't become a social worker. There's lots of other jobs, lots of other professions, but you have to have the kindness gene. You have to have a fire burning in your belly about stuff. Again, my views. So this interim report, if you haven't read it, I suggest you go onto the Royal Commission website. Don't have to read it all, but just get snippets and see how that interim report has played out in this final report, which was handed down in February. It has 148 recommendations, and I promise you, I'm not going to go through all of them with you tonight. But for those of you who are interested in aged care, and particularly aged care in community. I'm going to suggest you read some recommendations to get your head around where it's likely to lead and where we can continue to agitate to get some significant change. It's all about rights-based care and choice and control, which we've heard about. So what they are definitely saying will happen is the law will change. There will be a new Aged Care Act. They're also talking about integrating care and support. So a further push to get everybody in at the front line. So Centrelink, welfare, community services, health, housing, aged care, community care, everything needs to be integrated. When you read those recommendations, they're really talking about that MRN number, and they're really talking about e-health records, and they're really talking about being able to have an open view into an older person's needs and service access, with the person, of course, consenting through a range of different providers. And I'm sure all of us have different views around that. Just some key recommendations. They are going to build a bigger, a better, high-level bureaucracy called an Aged Care Commission, and they will regulate, monitor and fund. And they won't provide, they will not provide, but they will oversee the regulation and monitoring and funding of aged care services, government-funded aged care services. This commission will be big, much bigger than the Quality and Safety Commission that they are recommending gets abolished, and this gets put in its place. They want a pricing authority to set prices. On the one hand, government wants and has policies around marketisation, but on the other hand, they're saying, oops, we better price set and price cap. We can't trust the market and providers to set their own price because they'll go off and rip people off. Well, the reality is some did, but many haven't. If you want to provide good quality, safe aged care, you can't make a lot of money out of it. I genuinely believe it's not a money spinner, even though the marketisation of care and the policies of about 10 years ago promised new entrants into the market that, look, you know, ka-ching, ka-ching, come this way, you'll make loads of money. It's not going to happen. It hasn't happened, or it has happened at a cost, and the cost is poor care. Government wants to boost its governance, new Minister for Aged Care, and they want to have a whole network of offices across Australia. So what we're beginning to see is the bureaucratisation of aged care again, clearly responsible for regulating, monitoring and funding in these recommendations. And that'll be the first thing government will do. And they'll say, look, aren't we great? That's what we've done. We've spent millions and millions of dollars creating bureaucracy. But yes, we're getting to the care in a moment. I'm going to pause there. Any comments?
We've had a thanks, we've had an amen, Marika.
Sadiqa has said here, if the system is broken, what could be done to reinvent the system with respect to the early mention of Indigenous knowledge? In this neoliberal society, yeah, I hear you. I hear the compassion and kindness in critical. Having said that, how do we do it practically? Yeah, well, let's talk a little bit about that. I think that's certainly going to light Stephen's fire. So, yeah. Keep those questions and comments. Any thoughts that you've got, just dump them on the note, because there is no right answer. All we're trying to do tonight is to provide a big picture, a bit of a framework. What we do next over the next 5 years as a sector will help shape the next 20 years or so of aged care in Australia. It is fair to say that there is absolute political will to fix this system across all colours of government. Everybody wants good aged care. What is also fair to say is no one knows how we're going to pay for it, and governments are too scared to talk about the tax issue, because if we want good quality aged care, the reality is we've got to pay for it. We've got to pay for it. And for far too long, we haven't. I mean, yeah, we pay taxes, but those taxes don't necessarily go into here. And it's the question, the tax question for Australians is a question that we need to answer. The last Labor government, Shorten, went to an election as a winner, and he pretty much introduced, if you remember, a levy, which is another word for a tax. Didn't want to use the word levy. He thought he would trick people. And Australians absolutely, particularly older Australians, panicked. And what the Morrison government did was they played on that. You remember the last 10 days of the last election campaign was all about how the Labor government would tax you to the eyeballs and you would lose your house, your money, your super, all that stuff. Because, you know, no government really had the courage to say, it's great, these recommendations are awesome, but we have to pay for them. And that's something we all have to decide. And that's why this issue is political. Okay, so there you go. Recommendation 13 talks about embedding high quality aged care, diligent and skillful care, safe and insightful care, caring and compassionate relationships. Stephen?
Hello.
Yeah, which is great. You know, the word compassion has come in, empowering care and timely care. Nothing about that sounds bad. Sounds great. Sounds good.
You can turn good feelings into weasel words that you roll out to cover the fact that you're not doing anything about them, but you're just using the words to make everyone feel warm and fuzzy.
Yeah, and I think, again, the intent is that we all want that stuff. And I really believe the Morrison government wants this as well. And I'm confident the opposition and other minor parties who will have a say also want this kind of stuff. No one is going to argue with diligent and skillful care and safe and insightful care and compassionate care and relationships. No one would want to argue. Well, maybe some people will, but I'm sure none of us here would want to argue that.
No.
The question is how and who pays for it. I mean, ultimately, that's it. Heaps more recommendations. Things like, particularly in residential care, restraints will be regulated. There's going to be this urgent review of aged care standards and quality indicators. They are going to build, us. Government will definitely build a set of hoops for aged care standards and quality indicators, and we're going to have to absolutely meet those in order to get funding. They've said it very clearly, and that will have an impact on the sector. And I'll talk a little bit about what I think will happen because of that. They're going to introduce star ratings, you know, a bit like Airbnb. Gee, I really like staying at Stephen's villa at Avalon Beach. You know, great soft toilet paper and lovely fresh jam in the fridge. That's the kind of rating system. They will encourage customers to rate providers. And they've been talking about that for a really long time. It's now absolutely legislated written in black and white, and will be part of the standards and in legislation, I'm sure. Government to fund this thing called care finders, who are independent and impartial providers of information. And for us at CCMB, that's a critical recommendation because that's our service model. We are an independent and impartial provider of information, advice and guidance. The challenge that we have is that government will choose who will be the provider of that information, and it is most likely it will be local government or other quasi-government agencies, because, again, this is about risk and it's about managing that risk for government. They're talking about social supports to combat loneliness and isolation, because the research tells us, and all of you in this room will know, that people who are lonely and isolated require higher levels of care quicker than others. Care at home will be boosted with clinicians, allied, not aliened. I know what alien health is. I think it's supposed to be allied health. Alien health, that would be interesting. Allied health and assistive technology. There will be an absolute requirement to have those specialist and clinical care providers for home care, because they want to boost home care. They also want to boost allied health care in residential facilities as well. They're basically saying we don't want, and there should be no one waiting for a home care package. No one should die waiting for a package. There'll be a promotion of volunteers and engagement of volunteers in the provision of aged care. Support to, I really apologise, this was late at night last night. I don't know what informal care is, but support for informal carers. Better design of aged care accommodation. They've been talking about this for a while. What we will see, in my view, is group home-based aged care. So, a group of 10 older people living together in a high care facility, maybe on a site with, 5 or 10 groups of older people. There's already models of that everywhere. In Denmark and in Holland, there's the high-rise model where people live, 2 or 3 people live in one apartment, but the care is provided up and down on all floors. And of course, there was a load of recommendations about ATSI and culturally safe services, because the evidence is, and the evidence the Commission heard was that First Australians and those people from a culturally and linguistically diverse background were worse off than their peers. There's more recommendations. A really big recommendation is GPs. Primary healthcare is going to have a really big role. And GPs can volunteer to become accredited aged care practice, to be an accredited aged care practice. They'll have a much bigger role in the care of older people, and each accredited practice will have they'll have to make money, so government will give them some money, an annual capitation payment for every person enrolled. So, for example, Stephen, you're a GP, you want to be an accredited aged care practice, you'll get money for the amount of older people on your list, on your patient list, who fit the criteria. But you will also have a much bigger role. You won't swipe the Medicare card over and above what you usually swipe. They're talking about will give an incentive to GPs to become an accredited care practice. And I'm sure you'll have something to say about that, Steve.
I'll say something now, which is this scheme has been run out for chronic care, but
Keep
most
talking. I need a glass of water. Keep
Good.
talking.
I'll keep talking. Yeah, we don't want dead air. So whenever, unfortunately, the capitation, this is called the capitation approach to funding, which mimics the National Health Service. Whenever it's brought out, GPs usually find that they are worse off than they were before. Unfortunately, the way that Medicare is usually run is that when they bring in a new funding model, it looks great, but then when you actually do the sums, as they have done, and model the sums, you find that you are earning the same or less, and usually there is more reporting, with reporting being one of the, it's the golden fleece. So I'd like to think this was all, I'm going to be a cynic here as well. At the moment, whenever they say we're going to give an incentive to GPs going into aged care facilities, for example, there is a wonderful little funding model with new item numbers that everyone has to get used to, and it turns out that you're earning less money. So for a visit to an aged care facility, if you saw, for the first patient, you get $100, more or less, 89. But any subsequent person you see, you get $37. And then they're surprised that GPs don't want to leave their surgery, leave the fortress, travel time, finding the patient, the resident in the aged care facility, and then doing the consultation, and then doing the notes and prescriptions. So it's abysmally funded at the moment, and it would be good if we were all altruistic and say, well, these are our elders. We owe it to our elders to care for them. But I think most of us would say we are running small businesses, and this takes no account of the cost of running a small business. So there's my spiel on that. I hope that it's not a repeat of all of that, and that they're not just weasel words about having a bigger role. Because although they say that we'll have a bigger role, before we started, I said that one of the recommendations is that if we do need to use psychotropic drugs because there is a paucity of care available in an aged care facility, 3 nurses on for 80 people at night, and the resident is very distressed, and we say, well, I'd like to give them a good night's sleep for their dignity. We can't do that. We can't prescribe that drug. We have to ask a geriatrician to do that. So that would be the new recommendation. Now, early in the webinar, we were trying to find a geriatrician, the name of a geriatrician. Well, there are very few of them around. So it'll be interesting to see how that pans out. So in there's a myriad of challenges, which I hope we will won't be a Trump lie. I'm looking at it right now.
I'm so sorry we had to pause on that slide for a long time.
No. Look, I think your choice of a Trump slide, Trump picture, again, without being too cynical, and I love the intention, but between the thought and the deed lies the gulf.
Yeah, indeed. And I think that's the message around all these recommendations. What we do know is that there will be change in the way older people access, use, pay for services in their aged years, in their older years. We also know that there will be significant change in the way our sector monetises their models of service. That is absolutely going to happen. The needs of older people and their families probably don't change much. I've been in the sector for a long time and worked in the first community options program, where there was a significant reform that was on the tail of, the introduction of the home and community care program, where older people were now given real choices about staying at home and not moving into residential care. It came out of a policy shift, and there was a change in the early 90s around how people accessed care. People were living at home that 10 years previously would never have lived at home. They would absolutely have to be in nursing care, but they were staying at home. But with that came a new set of challenges for the sector. Let me just go through these slides and just go on through their recommendations, and we'll talk a little bit more about the impact. 25 talks about implementing into a new aged care program. They're basically saying that CHSP will go, restorative care will go. We're just going to have one system. We're going to call it level 1, 2, 3, 4, 5, 6, who knows, level 10 packages. But the CHSP, as we know it, will absolutely go, and there will be one assessment gateway, and the new commission is going to be the boss of that assessment gateway. It is likely, in my view, that assessment gateway will be pushed through to the states using the ACAT infrastructure. But you'll remember that the government got cold feet about 18 months ago. They were going to change the role of the ACATs, but they paused on that. Because, of course, there was lots of concern about, these RASs, not doing what they were supposed to do. It's my view that the RAS will go, the Regional Assessment Service, and there will be one entry point to assess your eligibility for aged care, funded aged care. I think that's important. Recommendation 59 is important to us here tonight because it's increased access to older persons' mental health services. And there's a bit of fluff in these recommendations, but basically a bit more money, and they will be funded, that the state and territory will be funded separately to deliver outreach services to people receiving resi aged care or personal care at home. So we're going to see local health districts play a much bigger role in the provision of services to older persons' mental health, a little bit like we now see community health centres providing high levels of support to people who are younger who have a mental health problem. I'm not quite sure how that will play out, but it will probably mean that many small providers, NGOs, won't be able to get money, and they probably won't exist in about 5 years' time. They will close again because of this major funding reform. Big recommendations around workforce development and support. They're talking about minimum qualifications. They do now too, but they're upping those quals. Better support, they're talking about a $5, on average, $5 an hour increase. They're talking about staff ratios in resi care, so all really great recommendations. And for those of us who worked in workforce development and support in the sector, tops, yep, we know, that's what we've been saying. So I'm a little bit like, yeah, let's see, because this is where the NULA comes into it, who actually pays. Just going to share my five takeaway messages, what I know and what I've understood. The first thing is, and I'll say it again, the Royal Commission's a political tool. It's about stalling for time. It's going to take a long time to fix, but it is an important tool, not only for government, but for all of us who are really involved and interested in changing the system for our older family members and older neighbours and older people that we love and care for. 18 major public reports and inquiries related to publicly funded aged care in Australia since 1997. The findings in this Royal Commission, they're not new, and many of the recommendations have been cited before. So my takeaway message is, and I do not want to be cynical because I don't want to be cynical, but it ain't nothing new. So what are we going to do about mobilising the really great recommendations that these commissioners have come up with? Of course, my other takeaway message is that the overwhelming evidence is that the current system doesn't work, but government really wants it to work. I genuinely believe there are good people in government on all sides and they want to make it to work. And I think that's a really good place to start. I think there'll be some oppositional support around how to make it work, but I think they'll be aiming for some bipartisan support, but not in an election year. So be prepared that the election platform for the next federal election will be about aged care. I'm confident it will be about aged care. It's going to take at least a decade to get things better, even if we start tomorrow. The reality is my mother, people that you love, will miss out. So we need to do better now, right now. So they need to invest in those home care packages immediately. And I know there's campaigns going around pushing for that. It's going to cost is my other key message, which I've said throughout this conversation. And so either taxes go up, funding from elsewhere gets cut, education, health, roads, government bureaucracy, who knows, or older people will actually pay more out of their pocket. They will have to mobilise and leverage off their own real estate, which is usually their own family home. And some of them are already doing that. Personally, I think it's going to be a combination. The cost of aged care is going to be shared. Remember the terms of reference. What can we do together? Well, it's really about pushing that responsibility away and sharing the love. I did say 5, but I've actually got 5 more takeaway messages. And the number 6 one is that the Commonwealth and state will need to work better together, which is something they've been trying to do since Federation. They will give the state money. The feds will give the state money, and they're most likely going to give it to the Ministry of Health, and they will most likely channel it through to the local health districts. I'm not sure I'm happy with that, but I'll wait and see. The other takeaway message is that there's a new sheriff in town. The Aged Care Commission will make it tough. There'll be loads of rules and providers will need to meet higher level tests. And I think the issue there will be that we will see a shift in the sector and we will see many operators close, which the government has been really seeking to do for a while, because it's just too complicated for them to manage, even though they want a market-based social policy model and let the market decide and let, all these services pop up. They can't manage the risk. So I think there'll be that new sheriff in town will definitely make it tough for providers. There's going to need to be bigger, better investment in workforce capability. They've said that. And my take-home message from the Commission is they're going to actually do that. They're going to start to do that, but it will all be through the lens of quality and safety, and it will all be compliance driven. So why does a certificate 4 person provide better quality and safe care than a woman who is caring, or a man, but it's most likely a woman, caring and compassionate and genuinely cares? She won't be able to provide that care through a funded model unless she does the certificate 4. So I think it's great if she can do the Cert 4, but I think we're going to have huge problems getting people to do Cert 4s and enter the system. But government has started already incentivising, calling for, starting early in high school, making working in aged care really interesting. I mentioned earlier that I supervise social work students, and I can tell you they all want to work with youth or mental health. When I say to them, aged care is where it's at, they say, no, I'm not really interested in working with aged people. And we've got to shift that. We've got to really shift that, because I think they're missing out, because the work is so rich and so rewarding and challenging and learning and all that stuff. My 9th takeaway message: assessment of eligibility will be streamlined, and the door to get into subsidised care will be really well guarded. So, they talk about common assessment. All they're really talking about is, can we just shut the gate? Because, make it a bit tighter. In order to get through, you're going to have to really meet significant tests. Now, that's happening now with ACAP, but it's going to continue. And my 10th takeaway message from the Commission's 100 and whatever it was recommendations is, we're going to have more audits with this regulator when we actually know that regulation has been ineffectual and it actually doesn't work. I mean, we've had regulation. All it becomes is compliance driven and tick a box. So for those agencies who are really good at ticking the box, and it's usually large ages, look at the big 5 nursing home providers. They had teams of people with glossy processes ticking every aged care accreditation box, looking awesome, but they still didn't provide quality care that was caring and compassionate. So I think that I'm going to have a problem with the compliance-driven bit of this. However, I know I might sound cynical and I might sound negative, but I'm actually really optimistic. I really believe we're going to see change, and I'm patient. I know it's not going to happen overnight, but it will happen. Sounds like a Pantene commercial. It will happen. There will be change, just like there was when the Home and Community Care Program, HAC, was introduced in 1985. We will see a new act, and there will be significant change. And service providers will adapt, and there will be good people providing compassionate care. And I'm sure many of you will be some of those really good people doing that, because I know I'll stay in this industry. I have babbled, and I am so sorry if I have bored you. I hope you got something out of that, but now it's your turn. Let's have a chat. What have you learned? What are you angry about? What are you interested about? Over to you, Stephen.
Oh, well, over to the audience. Steph here says I was the only one in my social work degree out of 90 that wanted to work in aged care. I think there is a reluctance to work in aged care, which I think is to do with our culture. It's an ageist culture. I know some people argue with that word ageist, but I think it is an ageist culture. And we like to relate largely to those who are 5 years older and 5 years younger than us. And it is a challenge. And I'd like to thank you, as Ruby Jo does, for distilling a complex report so well. That was Ruby Jo's comment. Fraser saying, if quality care not driven by audits and regulation, what would drive it? That's a very interesting question.
It's a great question, Fraser, and I think first of all, outcomes for people would drive it, and I think when I talk about a non-compliant driven culture, I'm talking about an outcomes-based culture. So not something that you can tick a box. Have you got a rail in your bathroom, for example? Tick, yep, really nice rail. Well, that's actually doesn't mean the person uses the rail. It doesn't mean that the rail is actually in the right spot. It doesn't actually even mean the rail is helping that person or reducing the risk. Just means they've got a rail in the bathroom. I know that's quite simplistic. So what should drive quality care is outcomes for people. So every person, and it's a big education piece for older people. We as Australians need to start planning for our aged care earlier on. So I need to start planning for my aged care earlier on. I live in this, house that's got stairs everywhere. We're not, my husband and I won't be able to live here forever. So we need to think through what kind of housing we're going to want to live with. We need to think through around where our mob will be, where our community will be. We need to think about, how we would like our care to be driven. I need to think about who I would like to make decisions for me if I can't make decisions for myself. So we need to build a culture that it's okay to talk about ageing. It's okay to plan for a good aged care, a good aging period in your life. I often hear some of my friends, and I'm in that age group now as a 55-year-old, people say, oh, you're still young. Yeah, I am, but I'm not. I'm at that age, where many people talk about aging is a bitch. It's terrible. All these terrible things happen to your body. And to your mind and to your relationships. We need to start saying, yes, some of those things can happen, but they can be prevented if you talk about planning in advance. So, Fraser, my answer to that is we need to shift from a compliance-driven model to an outcomes-driven model. That's that person-centred fluff that everyone talks about. It's in the report. But for me, what it really means is, what outcomes do I want? How will I know I'm ageing well? Well, it will be because I'm in a place where I feel like I belong. I'm still doing things with myself. I've still got friends and family. I'm really engaged in my community, irrespective of whether I've got frailty or cognitive impairment. I've still got stuff. There's a whole set of outcomes that will say, yeah, I'm old, but you know what? I'm having a good age time. And we're not there. We're not there at all, because this was about quality and safety, and it was about risk, and it was about managing risk. So I'll be certainly batting that drumming that, hitting that drum, whatever you do before dinner, because now sugar's low. About outcomes-focused care, for sure.
And Ruby Jo, thanks you for your personal thoughts and responses, which I do too. I can't let the evening go without what I know Marika and I and probably many of those people who have joined us tonight feel is that the community, to some degree, holds the answer to this, as they always have and always will. We can see that's emerged in terms of the difference between having a 1-800 number for domestic violence or sexual violence, and having a public display of concern that gets everyone talking. Australian of the Year catalyzes the response and the conversation. And so a conversation amongst all of us about how are we going to bring kindness and compassion into aged care, or even calling it aged care as if it falls into this separate compartment to any other care that we give each other. It's something that we can do and we can start to do today. I'm sure many of you already do. Marika mentioned it takes a village, and all the problems of the concept of it takes a village, shifting responsibility from government to community, doing professionals out of a job. But I always reckon that the professionals, there'll always be enough work for the professionals to do, and there'll always be too few professionals to do it. But so the role for all of us, especially as we age, as Marika said, is to find out who our tribe is, who our mob might be, who we may surround ourselves with, and start to provide care to our neighbours. If anyone wants to go into a more formalised model, you can contact CCMB and go on to their Compassionate Communities section and join one of the death cafes, which they talk about aging as well as death, but so that you can start straight away. Feeling disempowered and there's nothing we can do is very dispiriting, but there is something we can all do, and that lies within Compassionate Communities. To me, that's one of the answers. Yes, more Cert 4 workers, more GPs willing to go into aged care facilities, more RNs, better run aged care facilities, more packages. All of this is true, but I still feel that it will never meet the need. And there is one thing to be cared for by professionals, and there is another one to be cared for by people who know you and love you and are your neighbours, and who are very good reporters when something's going wrong. You don't need an audit. You can just say, oh, Mum isn't looking very well today, or Mum's shower rail's fallen off the wall of the bathroom. There's nothing like people who care doing the audit. So there's a question. What is the contact info re CCMB Compassionate Communities? I'll let Michelle put that up. I did a webinar, which is available on the PHN website on Compassionate Communities. It's a bit long. I'm afraid I couldn't stop talking, but it is there if anyone wants to go on it, or contact me and I'll send you the link to it. It's also on YouTube. You just look up Sydney North Health Network, my name, and Sydney North and Compassionate Communities. Michelle's given the number for contacting. And now let's see, any more questions coming in, Michelle?
There is one that's not been answered. It says, on top of who's to pay for a system restructure with record federal government debt due to COVID-19, is this reluctance for public paying for systemic change of aged care system only going to be magnified?
Look, I did see that comment before. Thank you. I think it was anonymous, but thank you. I think that's what I'm saying about it's going to be political. It's really around how prepared we are as Australians to pay for good quality aged care. And Stephen talked about, you know, our ageist world. We don't like to hear that we're ageist, but we are. We exclude older people all the time, and it's been hard, and it's obviously been to the detriment of many people and their families. One of the so I think the issue is that this will become a political football, and we may get some stuff out of it, which is why I'm a little bit optimistic. You see, I don't mind a bit of political argy-bargy. Unfortunately, there are winners and losers in that, but I think it's the only way that we'll get some traction. One of the things we didn't talk about in this, and I just wanted to close my final comment, is this commission, Royal Commission, really focused a lot of its attention on residential care and on formal provision of funded services. Now, the reality is the majority of older people actually not in the aged care system. The majority of the older people are cared by, formally by a GP anyway, or a daughter or a husband or a wife or a sister or a neighbour or their compassionate community, whoever's around them. Or sometimes people lack informal supports, and they will link onto you know, formalised volunteer services to help them through. So majority of older people are not in the system. They are just as much at risk of poor quality care and poor and unsafe care as others. But of course, in many ways, government doesn't want to regulate that, nor should they. But I think we all know, and those of us who work in care, the risks that people face, even at the hands of their own family. And those of us who worked in child protection, I think Jessica shared that with us earlier. Older people also are at risk at home, and they're also at risk through the informal sector. And I say that as someone that sat on the Guardianship Tribunal for 10 years, and just had hearing after hearing after hearing of older people who were really put at risk. And they were put at risk because they were isolated from a caring community. They were exposed and vulnerable because they did not have an informal, compassionate network around them to say, oh, you know, I haven't seen Marika for a while, but did you notice that the paper boy keeps popping in and saying hello? You know, and that I have to say to you, the paper boy runs on the tribunal were very notorious for abuse. Older people would be groomed, particularly those who own their own house and had no family. What happens is that when a person becomes isolated from their community and does not have this group of their own network of support, that's when they become unsafe. That's when they age badly. That's when they run into problems around quality and safety. So we need to turn our minds, and Stephen talks about compassionate communities as an absolute answer of future-proofing good quality and safe aged care. That's what I'll be selling, Stephen, for the next couple of years.
Me too. I've seen the rest of it, and we need all of that structure, and we need the professionals, and we need the aged care facilities. But in our own neighbourhoods, you don't need a police check, you don't need a working with children check, and you don't need to bang on the door of the aged care facility and say, when can I visit? You just have to drop a note into your neighbour's letterbox with your number.
Yep.
And that's how it starts. And Hugh Mackay, it's not everyone's cup of tea, but he doesn't specifically speak about compassionate communities, but he's always been a very strong advocate of our neighbourhood, and that as a solution to some of the horrors that have been exposed by the Royal Commission. So raising that in the community, the horrors, but sometimes just horror stories don't do it. There weren't enough good stories, and there weren't enough stories of how such a it takes a village approach can help and do great things. So there's one more message come in. Okay, I don't think that's relevant to that. So if there are no more questions or comments, we can carry this conversation on. There will be another meeting in a couple of months' time, and this is a wonderful, very committed group. There's a strong group of us all, and hopefully we can celebrate the ending of this COVID era. I did get the mention about COVID vaccination and how that's going to be rolling out, and in a couple of months' time, that will be a good time to talk about this in the community, because there will be older people wondering, is it safe? What should we do? How do we get it? So we'll certainly, I think, work that into our next meeting, which hopefully will be a face-to-face meeting. So watch this space. Certainly contact us by email or through Sydney North if you want to put any ideas, or through Mental Health Professionals Network. And I thank you all for coming. I thank particularly Michelle for all the work that she has done since this network started to run these webinars and to build this core group of people in our area who have a passion for the care of older people. So Michelle, really, you've been very out of the limelight, but you're always there to help set up these meetings with ideas of what we should have, and also those touches that are so important, which is the bunch of flowers or the box of chocolates for the speaker. So it's that kindness that you show, and you show it in your work, and you show it in the way that you have contributed to this network, and you will be missed. And I thank you for all the work you've put into it. Maybe you'll be an attendee and not an organizer. It'll be great to see you come up on the lists. So I thank you all, and look forward to seeing you in a couple of months. Thank you, Marika.
Pleasure.
Thank you. It was really, the messages that are coming in, really appreciate how you've distilled it.